Okay, well, let's get stuck in, I think. Joseph, maybe you could give us a view, maybe briefly just touching on what the key challenges are, but more importantly, what our responses ought to be within Europe, and perhaps, I mean, it's a global issue too, so.
Actually, I was also very inspired by the reasons to be cheerful. And one thing, Vivek, that always gets on my nerves is this sort of whining about all the challenges, and we keep repeating them and how big they are and how hopeless everything is. And I felt that last presentation told us, and that's exactly the way I wanted to frame perhaps these initial remarks. First, it's not just migration, aging, environment. It's not only viruses crossing borders. We need to look at issues, of course, of health workforce, but we need to broaden all that. Commercial determinants, to me, are perhaps more than a pandemic than the virus of the COVID virus itself. So what I'm saying is perhaps there are reasons to be cheerful in the sense that the pandemic, in the AC, not the after crisis, but the after COVID world, health is no longer, I hope that doesn't sound gender biased, a Cinderella, but perhaps people like Ilona and I, and many of you have been in this field for a while, we see now health dancing with the prince, with the Minister of Finance, being in government. I don't know where you see that in Malta. You know, your vice prime minister, deputy prime minister comes from health, Chris. So we see health as an opportunity to, health now is cohesion, health is security, health is sustainability. But as for Cinderella, 12 o'clock is getting close, and where's the window of opportunity? What can we do in that very short window of this very short honeymoon? Also, actually, we are looking now in the observatory at health democracy and health and democracy. There are plenty of data that people with poorer health tend to vote to populist parties. So you now can go back to the policymakers and say, hold on, health and coverage is good for many things, for your economy, for your cohesion, for your social peace. So we have that opportunity. And in that opportunity, we can see migration as an opportunity. We see the health workforce crisis as an opportunity. Aging is so impressive. It's so impressive. I didn't know that Malta, as you said, has a department for active aging. The Observer has been doing a lot of work about healthy aging. There is an opportunity on the aging and the healthy aging. And that's on the challenges side. As you see, I'm trying to take very much a positive side. But on the intervention side, we've seen, my colleague on the left, Ilona, is a real expert on global governance issues, but we've seen questioning, even within the EU, subsidiarity, believe it or not. Not only because the viruses cross borders, but because they are seeing other things are crossing borders, and we need to work together. Countries are prepared to renounce some of their sovereignty at WHO level and global level for global governance tools. There is a debate more about how we use trade, how we use foreign policy. Look at, if you have time, and the new global health policy from the EU that is going beyond the usual tools of development, the usual tools of One Health, which are very important because going to other policies. They go to, and they talk about trade. They talk about multilateralism. So I just wanted to frame that a tiny bit. And one final way to frame that as well, that we are pushing very much in the observatory, is not only health in all policies, is not only what other sectors can do for you, which is extremely important. You work with trade, you work with agriculture, you work with economic development, but also empowering ourselves, what we call health for all policies. It's not only the environment co-benefits on health, okay, the health co-benefits on the environment, sorry, but the environment co-benefits of health, as we heard earlier in the first excellent panel you were running on all the impact of the health system and CO2, but there are many others. The impact of health on education, the impact of health and health systems on gender equity, the impact of health and health systems on poverty. So we can also take that dimension. So the future is not rosy. I'm not gone crazy totally here. Don't worry. I'm not quite there yet. But I do believe we need to take a much more constructive approach and take this opportunity before 12 o'clock. Thanks.
Wow. This is taking a turn that I wasn't expecting, because this is
Sorry.
No, it's good. Because
discuss
it's seeing these things about population change and aging and migration. We always see them as challenges. You've described that we maybe need to flip this a little bit on its head and look at them as opportunities. Also, you've talked about how these challenges can make very explicit the links between health and societal security, and the security between countries as well, and it brings that the idea of health to the fore. So I want to explore that a bit more, kind of going off in a direction I wasn't expecting. Ilona, maybe you want to expand upon that. What are the other opportunities that we might see from the population changes?
Well, I think actually, continuing from Joseph, that these new areas that emerge actually would help us address the challenges we have with population aging in quite a new way. I mean, first of all, our health workforce is aging. And if you look in a whole number of countries, you have about 1/3 of physicians are now over 55. So what's going to happen the next 10, 20 years? Because there is no physicians coming afterwards. So the physician gap, the nurses gap, you have all these workforce gaps. People, as we know, after COVID, have left the health system. They no longer want to work there. We've heard that actually the environment becomes an issue to attract people. So we're in a totally new situation. We took it as a given that we had people working in the health system. We can no longer take that as a given, which relates us to very contentious policies in society, and that is migration policy. So if the European Union is looking at legal migration, the first question has to be, to what extent does the European Union, and actually the Belgian presidency is going to put a focus on that, very concrete entry point for everyone, is to ask to what extent is the health care workers issue part of the legal migration agenda? And how does one approach it? Because at present, individual institutions and individual countries are competing. The hospital director X, we heard from the Charité earlier, is traveling there and says, send your nurses to us, and developing special programs. You here in the UK are reaching out to the Commonwealth. India, Nigeria, Philippines are the major providers of nurses here in this country. And it also means, if you really want to look at the future of healthcare, who is going to provide it? I mean, are we going to see a system like has developed in the Philippines? We actually produce nurses for the others, and we get the remittances to develop our society. Is India going to be the country that creates, educates the doctors for the rest of the world, and everybody can have access to it? Mm-hmm. Would we share costs in that kind of training and say, we need you, therefore we also help pay for that education? I think we have a whole range of new future issues related here. And I'll just say a small bit and then maybe come back afterwards. If one says, partly, excuse me, where should that money come from? The thing is, if you look at the whole structure of the population and the diseases, and you look at the fact that now in Europe, we have 60 million people with diabetes. We have over 50% of the population overweight, and we have about 17% of people obese. If we look at the costs of these non-communicable diseases, you mentioned the commercial determinants. If you look at those costs, you could pay for a significant part of the other challenges that we face in the healthcare system, including the mental health challenges, including the creation of a new type of workforce, etc. So in the European Union, obesity costs the overall society 70 billion per year. Now, just sort of think what you could do with that money. If we're saying there's no fiscal space to pay for X in the healthcare system, there's no fiscal space to pay for childcare going into health and all policies and inequities. So I think, one could be positive and say, if I turn here, I would actually get a solution there. But we're not willing to do that, because if you look at the discussion around, processed foods, whatever in the European Union, you're not getting anywhere in moving forward. So you had an attempt here in the UK. I understand that's not moving as well either as one had intended. So, if we don't invest where it matters, and if we don't regulate where it matters, we're not going to be able to solve the problem of our healthcare systems and make them sustainable.
Okay. That's good, because you haven't actually shied away from those big challenges, but also you've talked about solutions. In many ways, you talked about the globalization of both the health challenges and the globalization of health solutions, potentially with workforce being mobile, etc. Maybe let's talk about specific implementations, and this I'll turn to you, Jo Etienne. You in Malta, you have to implement these solutions. You're looking down the barrel at aging populations. What are you actually doing in terms of the kinds of solutions that have just been suggested?
Right. First of all, thank you for having me here, and good morning to you all. I will talk from the perspective of me having a number of hats, because besides being Minister for Active Aging, I'm actually a cancer surgeon by profession.
Right.
So, and I'm a lecturer in surgery as well. Most of my patients are obviously older persons who suffer from very serious illness. So I have the perspective of being a healthcare worker, and we're talking about healthcare workers, albeit my time with patients is very much reduced now, and then the perspective of strategy, the politician. You might wonder, how can I reconcile both at the same time? There are obviously very conflicting issues at bay there. As a healthcare worker, I pretend that our patients should have everything I ask for. As a politician and a strategist, this is completely different. So, talking about Malta, Malta is a tiny country, 500,000+ population. Migration, and here we're talking about migration for recruitment purposes, we're not talking about any other form of migration. Migration is extremely important in Malta to our country, so much so that over the past 10 years, our population has ballooned by 1/5. And that 1/5 of the population, the vast majority of those people are healthcare workers. What does that mean? We are a microcosm, but we do reflect many of the issues which our neighboring countries and other European countries are experiencing. I think as Europeans, we tend to think that if we have a problem, if Europe has a problem, this is a global problem. And that's already, I think, pretentious, and that's a bad start. The problems we are facing with the workforce, with the healthcare workforce, are our own, of course, and we have to deal with them. And just to give you an idea, as a ministry, we look after long-term care beds. And in our country, a country of 500,000, as I said, we have something like 7,000 long-term beds. I will not be incorrect in saying that the vast majority of our carers and workers are third country nationals. We have a particular geriatric facility which houses 500 older persons. And the third country national ratio of workers in that facility alone is 98%. What does that mean? Our population, if you look at the 20, 30, 40 age group, we don't have, for us, it's impossible to extract from that segment of the population the healthcare workers that our country needs. It's a mathematical certainty. It's a statistical impossibility for Malta to sustain its own workforce. So how do we go about it? We obviously try to recruit as many third country nationals as possible. We know we have stiff competition from our neighbors, the United Kingdom, Ireland, Australia, New Zealand. This is no secret. And this is very stiff competition. But that's not even the start of it, because we can have you can have all the healthcare workers you want. But the trick, the catch, is in retaining that workforce. So what we're trying to do is to emphasize on education, education, education. We try to create opportunities. We have a number of master's degrees. We have job mobility, care workers to nurses, nurses to doctors. Ilona has mentioned India as the possible, potential future powerhouse for physicians in the world. I have to say from our experience, India is our powerhouse for nurses and care workers, and they do an excellent job. Do I receive complaints about our strategy, about our operations? Of course, tens every day. And it's not because third country nationals do not do their job. They do their job fantastically. But one has to remember that here we're dealing with older persons. Older persons who may be familiar with English, but English is not their first language. So as a doctor, I know if a patient is in pain and if a patient wants analgesia, wants painkillers, he will always express himself in his own native tongue. So what am I saying? Migration is of the essence to maintain a healthcare workforce. However, education is extremely important, because if we're going to talk about patient-centered care, this is crucial. We talk a lot about patient-centered care. Are we measuring the proper outcomes to assess that we are really providing patient-centered care? Some thoughts for discussion.
Thank you. So, I mean, the discussion so far is very much centered around the aging population demands greater, especially long-term care. We need workforce solutions in particular for that. Some of those solutions may come through migration, but there are issues around that. We haven't discussed what it means for the country from which they're emigrating as well. That's an issue that we need to discuss. But I want to take a slightly different turn now, which is talking about, Cepheid, as I understand it, is a diagnostics company, a diagnostics innovator. But a general question is, we've talked about the sort of shaping policies that might address some of these challenges, but what is the role and responsibility of the critical part of the healthcare ecosystem, the innovator? Maybe you want to focus on diagnostics, but the innovator in trying to address these challenges of population change that we're talking about.
Yeah, thank you, Vivek. As you said, for those who do not know Cepheid, and I would emphasize Cepheid, not Kefid, because we have nothing to do with cephalosporins or cephalosporins. It's like Cepheid from the source. So we have a lot to do as a diagnostic company, as a healthcare company as well, when it comes to the population change. The first thing is innovation. And so when we talk about innovation and the population change, we need to think about the population change as just mentioned in two ways. one the aging population and one is the migration. And both of them, they carry challenges when it comes to the diseases and the set of challenges associated with diagnosing those diseases. So when it comes to aging population, we know through the COVID that those probably elderly population, they were at higher risk of developing complications for COVID, for morbidity and mortality in general. And so it becomes very critical that we diagnose those at the earliest possible time. And this is basically the innovation that we bring, which is democratizing diagnostic tools, whereby we can make those accurate tests available at point of care. And so if you were with me on a virtual call, you will see one of our devices parachuted in Antarctica during the COVID times so that they can do testing. And we're talking about an IVD, in vitro diagnostic, that is cleared and approved by regulatory authorities. It's not an antigen test. And we have another device in the International Space Station. So bringing those to the patients everywhere is very critical, especially when we talk about the elderly population. Chief Executive DAM, Jenny Harris, talked about point-of-care testing and the fact that now we have access to those tools. That's exactly what we're talking about. And it's not only COVID. We're able to diagnose other diseases like TB in Africa, for example, a big part of what we were doing, and that was a major inflection point for the company. Hepatitis C elimination, and all the campaigns going on globally, because we introduced a finger stick test that can give you the answer in less than an hour so that you can test and treat. So all of those things around bringing the test closer to patient. That's the first thing. The second thing, Roland Dries talked about also as part of the discussion about antimicrobial resistance and some of the challenges there. And when we talk about migration, we know for sure that some of the countries, for example, they have higher incidence of carbapenem resistance. And those are coming, for example, to Europe, to many countries in Europe. And so we need to have also the diagnostic tools available in hospitals, large, smaller hospitals, and so on, so that we can diagnose those patients within an hour, rather than go to traditional tools that will take probably a day or even few days before you get the results back, and then moving towards managing those patients in a better way. So all in all, as I said, dealing with population changes, whether it is the aging population, of bringing those innovation closer to patients so that we can test and treat, triage those patients in the best possible way, or when it comes to antimicrobial resistance, diagnostics play an important role. As you know, we were talking about the different also things during the earlier discussions when we talk about sustainability, affordability, all of those things that we can bring with diagnostics that would make it more sustainable for the healthcare system. And we talked about some of the also early themes, health economics and sustainability, how we can also show the healthcare systems whether the diagnostics that we are working on is value for money. Unfortunately, some of that, there are so many challenges for the adoption of point-of-care testing. Many of that is overshadowed by the fact if you diagnose, you need to treat, and usually treatment is expensive. So people, they avoid the whole thing to start with, unfortunately.
Okay, thank you. We've in the conversation so far, I think I feel like I want to join the dots here on, because the key challenge, and I want to focus on Europe, because this could be such a huge topic that we could discuss for the next 2 days. But let's focus on Europe, where we've got aging demographics and we've got mass migrations likely and existing and likely. we've talked about the role of innovation and of technology that can assist. We've talked about the workforce challenges and workforce solutions that might exist from migration. Joseph, you talked about sort of broad policies, health in all policies, commercial determinants of health, what we do around diet and so on. Can we tie this together into how do we address this challenge of migration and aging population and chronic comorbidity in that aging population? What would be, it's a hard question I'm asking you, and I don't mind who answers. What a 4 or 5 point kind of, these are the things we must get on top of to address this. I'm going to ask each of you in turn. I think I'll start with Joe Etienne and Chris come round, if that's okay. If you're happy to.
Oh,
but you can pass the.
well, I think I'll give you 4 important issues we need to seriously think about. Migration, I spoke a lot about it. It's not enough. We need to use technology, and we need to get our older persons comfortable with technology and our workforce comfortable with technology. Here I'm talking about telemedicine, but it goes beyond that. Assistive devices, wearable devices, I think they're here to stay. I spoke about education and the opportunities to healthcare workers to move in their jobs, but very importantly, we are sort of, our environment is dry of healthcare workers. Retirement ages. Should we not seriously think about retirement ages? If we have a 65-year-old, very experienced nurse, should she not or he not be given the opportunity to work even more and be more productive? Those are the 2 main important issues. I don't think I have the time to expand on that.
Okay. Joseph?
I think on the migration, listen, either we have more babies and start reproducing, and we don't seem to be doing that in our countries, or we start understanding there's some data that 1/3 of the young workforce will come from Africa. Now we are protecting our borders, and in a while we'll be fighting to open our borders to understand that. We know that there's some data as well, how good or bad is not, that relating with that around a third to a half of the kids that we now send to university should go into healthcare and social care to take care of us. So these are realities that we need to face from the broader political, economic perspective and social sustainability perspective. So, and there are many solutions to go there. On the migration, of course, I'm sure, I mean, you are totally on board on that. We have to be cautious about, as you highlighted, and if you look at the code of practice of WHO, there are a multitude of schemes in which you can get win-wins, support, compensation, training, co-training, returning, and so on. So I think that's one way forward to at least to deal with that. But there are substantial economic, social problems and political problems that we are not facing as a society, number one. On healthy aging, again, we need to work together on that, but as you could tell me much more than I do, is the green economy, is the contribution of the aging to society. Have you ever looked at the productivity of the informal care that the elderly do to the others? The role we take in kids, the role of contribution to society. That we are measuring, we need to look at that. We know as well, it's not true that we live longer in worse health. Thanks to the developments in health promotion, but also on a number of disability measures, improving disability and so on, our aging can work for longer and spend for longer. They're a real source of capital and economic growth, the economy. Let's look at all these kinds of measures, because that's very much innovation, yes, but innovation we need to work on. I wrap up. Innovation is something we need to work together, because there's a lot of innovation, and you're making that point, that is not really innovation, okay? There's no really cost-effective or adding anything. Innovation that we need to regulate, need to share. We need to do joint purchasing. We need to work together through WHO, through the European Union, to access to that. AI, the great promise of AI, unless we work together on AI, we have a real problem because all the benefits of AI, and in that sense, the European Parliament is taking the lead. And I know Britain is doing quite a lot of work, but these are global issues. We have to work together. But let me finish. This probably is the last opportunity.
Yeah, please, because we've
To
only
me,
got suddenly time up to 5 minutes.
the lesson, Vivek, from people in this room, the lesson when people ask me what is the lesson of COVID, there are 3 lessons. Communication, communication, and communication. Okay? Right. We are lousy at framing this debate in a way that we get support for these agendas.
Great, thank you. Ilona and Amar, I'm sorry, suddenly this has jumped from 10 to 5, unexpectedly. We've been through a wormhole or something. Go on, yes, go on.
Yeah, okay, I'll try and be precise. First of all, when I started to work for WHO in the 1980s, there was a Swedish report. And this Swedish report said, if we don't change our healthcare systems, we are going to, in the early 2000s, be in a situation where one Swede will take care of the other Swede. Mm-hmm. So this whole push of all the care that we need in our society, if we don't address it by changing our healthcare systems and the way they work, we are not going to be able to solve the problem. So irrespective also of all the migration things we've discussed, if we keep having a system that is so hierarchical, that doesn't allow a whole chunk of people who work in the system, mainly female healthcare workers, to take on responsible things, or pharmacists, because medical associations think they shouldn't be giving an injection, then you're not going to be able to reform your system, and then you're going to have a heck of a lot of problems also in relation to who is willing to come and work. So first of all, we do need to address those things in the system, and community care plays an incredible role here. And there's fantastic examples very concretely for older people, for example, in Iceland. The second is we do need global rules. And these global rules have to be worked on in terms of, for example, the accreditation of healthcare professionals. I was in a situation where an African nursing school director asked a representative from an accreditation body to say, how can I best be accredited? And the answer was, think twice before you want that, because all the nurses that will take the exams in your organization are going to leave for Europe, and you're going to have none left in your African country. So we have to work on a global accreditation system also, where doctors who have been well trained in one of their countries then can't work elsewhere, except, despite the fact that we need them. And the last thing is that we do need to follow up. We need healthy older populations. And unless we put a real focus on prevention in our healthcare systems, we're not going to get that. Then our systems will be too expensive. You have to operate them. And we won't have the people we need to care for them following it through. So I think those 3 things are absolutely critical.
Amar, last words to you, and we can encroach a little bit. There's a break next, so you can encroach a little bit on that, but yes.
Yeah, sure. I would start from prevention and say early diagnosis. It's going to be very critical that we provide the tools for early diagnosis at point of care. So as an industry, the first thing that we need to do is keep innovating, making those solutions more affordable where it's needed, and at the same time simpler to operate. I'll give you an example. One of those tools that is an IVD solution can be run in a CLIA-waived environment by someone who is 12 years old. That's the simple solution. It does not need a lot of training in order to do that. So that's something we need to keep doing. We need to bring probably more comprehensive panels into the marketplace that would be able to look at multiple diseases at the same time in a record time, probably 15 minutes or less. So that's our commitment as an industry, between the innovation and the affordability also of those solutions and simplicity. From healthcare systems, we need to make sure that we have a learning healthcare system. We cannot go back on the learnings that we had during COVID, when we have seen firsthand the need for early diagnosis at point of care, and now we go back to a status whereby this diagnosis only took place at a hospital that will be overwhelmed quickly with the next pandemic. And so we need to build on that learning system, the learning healthcare system, so that we can provide, again, diagnostics where it's needed at the point of care. So we learned a lot the hard way during the pandemic. Now it's the time to build on those learnings.
Great, thank you. We're out of time, and normally I would take questions from the floor, but I think we've got a break now till about till 12:10. So if anyone wants to ask our panel questions, if I could ask you just hold on, and maybe you could just come down and chat to them, if that's okay. So we've got a break now until, please be here just before 12:10 so we can start promptly. Thank you very much.